Good evening, Singaravelu sir.
Sir, good evening, sir.
How are you doing?
Yes, sir. Simultaneously, today, TOT also going on.
Good evening, sir. Nikhil here.
Good evening, sir.
Hello,
Hi,
Nikhil.
Nandish sir is there.
Sandeep Trivedi.
Good evening,
Wow,
Nikhil.
so
Sandeep sir is
nice.
there.
everybody.
I am not able to connect Neelam Mohan, madam. I think she is busy with that strike TOT today.
Yes.
So I am not able to connect her. But let's wait for some time, and at 9 o'clock we can start the thing.
Okay.
We already have the president elect here. So,
Thank you,
if,
Nikhil.
sir, if madam does not join, you
Okay.
start and given this thing.
Sure,
And
sure.
Sandeep sir is also there.
Sandeep is there. No problem.
So both of you we will start. I've also
Yes.
asked Ruchira madam to join, but she will join after that inauguration there.
Okay.
Yeah, madam will join in some time.
Okay. Aradhna madam is there? Yes, she is there.
Yes, Dr.
Yes.
I am.
Yes.
Dr. Pinaki has he joined? Yes.
I'm there. I'm audible.
Yes, Pinaki is looking as smart as ever.
Thank you, bhai.
And has Dr. Venkatesh joined? Dr. Venkatesh, sir?
Venkatesh sir is not there, I think so.
I'll call him.
नहीं दिख रहा है.
We will just wait for 1 minute and we can start the program. Good evening, Venkatesh sir.
Hi, Dr. Nikhil.
Good evening.
Good evening. How
Good
are you? Am I audible?
Good evening, sir.
Good evening, Dr. Azan.
Sir, good evening.
Good evening, sir.
Good evening, Dr. Vinaki. How are you?
Good evening. Fine, sir. It has started raining here.
Oh,
So we're
really?
getting, yeah.
Bangalore also, day by day we see clouds, but no rain.
Oh,
But too hot it seems, isn't it? Daytime, I think at least.
yeah, it's humid and it's a sultry weather.
Okay.
So temperature is started soaring up.
Absolutely.
I think we can start the program.
Yeah.
So anyone from IAP is there? The recording is going on. The IAP activity person is there. I can see him online.
Recording started.
Recording started.
Yeah,
Okay.
yeah. Okay.
So good evening, everyone. I welcome you today on behalf of IAP DG Academy. Today we are presenting the first case, the first journal club presentation that is our series of learning with journal and research work. Basically, the concept behind this thing was that we have journal club which are being presented by at multiple places. But what we thought was let us have some original articles and let us have someone who has presented those articles on established journal platforms, and we can hear from them that how the data was stratified. We can discuss its implication with the expert there. We can see how the statistics were carried out and this thing. So I would first like to welcome all the CIP members. First of all, Dr. Neelam Mohan, our energetic president. She is attending one
Sir,
more.
there are two systems happening, sir.
Yes.
Hi, I'm here.
Yes, ma'am. So she was at another inauguration of antibiotic TOT, and I was trying to contact her, but she's here bang on time. So
Welcome, ma'am.
So there are two systems running together, sir.
That's okay, Saji. Don't worry. We will divide ourselves. Thank you. Thank you. You got muted, beta.
sorry.
Dr. Nikhil, you got
Yes, ma'am.
muted.
Sorry, ma'am. Sorry, ma'am. So I would like to first welcome our president, Dr. Neelam Mohan, ma'am. Dr. Singarvelu, sir, the president-elect, sir. Ruchira, ma'am, is also going to join. She is also going to connect.
She's already joined.
She has joined. Yes. So I would like to welcome her also. I would like to welcome her also there. Hello. Am I audible? Yes. So I would also like to welcome her. We have a West Zone President, Dr. Sandeep Trivedi, who is also here. I would also like to welcome him. We will start first with few words from Neelam Mohan ma'am regarding her vision. And this is the first program. And
Nikhil, sir, please unmute.
Yeah. Am I audible? Am I
Yes, ma'am.
audible? I think
Yes, ma'am.
there was a lot of disturbance. He was trying to mute. Thank you so much, Dr. Nikhil Pathak. And we have Dr. Singarvelu, our president-elect, Dr. Ruchira, Dr. Alokji, and all the other. See, I can see Sandeep Trivedi, and I'm sure the other vice presidents who joined on this forum. Thank you. It is very important in our day-to-day life, not only to be updated clinically. Life is adhuri if you eat the same thing. Like we always say, there should be 7 things that you need to eat in nutrition, don't we? I mean, every day if you eat rice, dal, you're eating carbs and protein, but you don't eat vegetables, fruits, seeds, nuts. You won't get the vitamins and minerals. Similarly, I think in life, similar about learning, while we talk about clinical things, it is extremely important for we Indians to understand how important it is to give to research. And those of us who cannot give time in day-to-day research, at least can be taught on how to read papers and what is new, people are working, because science is nothing but evolution. Who better than us can understand that every day what you and me practiced 2 decades back, we laugh at it, so many things, and we do differently. Of course, there are some golden things like, whoever about resuscitation where we talk about it. But today's topic, I'm very grateful to my IPDG team under the leadership of Ganesh and Nikhil and the other team. Thank you all. And as you can see, we got a little late, a couple of weeks to start because the first week we had a setback, being busy with Pericon and all that. So this was something which was waiting. We're going to have 2 days in a week. And now we've just set the program for Fridays, 2 days in a month. We will do journals, and the other 2 days we've kept Life Beyond Pediatrics, where we will talk something beyond. It could be finance, it could be something else, which we need to understand about life beyond the pediatric. But when we talk about pediatric, this journal was something which I wanted to start, where I think something which helps to change our practice is extremely important. When I was reading this journal today, I was quite impressed myself. It's like, I want to know what is the answer, like caught clamping 1 minute versus 3 minutes. But what is very interesting is we are just not giving you in a simple style. We are going to have experts, as you have seen, and these experts are going to be moderators, experts, felicitators. We have Dr. Pinaki, Dr. Saugata Chaudhary, Dr. Bijan Sar, Dr. Venkatesh, all of them who are going to make us understand that paper in a way that you and me can decipher it. So that is the theme beyond today's program. And I hope we are able to come out with interesting every month. And we urge all of you all to keep sharing important journal which come, so that maybe to Nikhil Pathak, who can go through it and then decide which ones to choose. And I am thankful to all of you all. I know it is a novel idea on a digital platform, but I'm sure the clinicians should start appreciating and understand the importance, because not only the residents, they should also get addicted to this, to the journals. So I really wish you all a great future to come with in this journal club. And this club really becomes popular amongst all of you all. That's my hope and vision. Thank you so much for giving me an opportunity today.
Thank you. Thank you. We would just like to have few words from Dr. Singarvelu, sir, our president-elect.
Thank you. Thank you, Dr. Nikhil, for giving this wonderful opportunity. At the outset, I really congratulate our president and our entire team for bringing us such a great academic activity, which is the need of the hour, not only for the interns and others, for the practicing pediatrician, because the first day of this topic, cord clamping, 1 minute versus 3 minutes, how it is going to reduce neonatal anemia, and so much of things are happening. A simple intervention can change a lot in the outcome of NMR and all that. Surely this journal is going to be very useful for today, and the speakers and the moderators are known for their reputation. I'm sure that this will be very useful to all the practitioners. I really congratulate my president Neelam for bringing such good initiatives. Apart from routine activities. These are all the thing which is needed for practitioners and others to get stimulated for doing something so that they will learn what is happening, new things. So without wasting much time, I don't want to stand before science. I wish all a happy learning and all the presenters to do the best so that in future it will have a lot of, right now in the Zoom there are 50 people, but in Digi, a lot of people will be watching and definitely it will be useful to all. Thank you, sir. Wish you all the best.
Thank you,
Happy
sir.
learning. Thank you, Nikhil.
Thank you, sir. Sir, so we also have our Honorable Secretary, Ruchira ma'am here. Just few words from her before we start the program.
Thank you, Nikhil. It truly is a pleasure to have this journal club on this IAP DG app under the leadership of our President, Dr. Mohan, and President-elect Dr. Singaravelu, sir. So a warm good evening to one and all. I'm sure this initiative of Indian Academy of Pediatrics, it will create a vibrant academic platform where evidence, experience, and ideas, they can come together to strengthen the pediatric practice. Through this digital platform, we are sure that our members across the country, they can stay updated with the latest research and translate knowledge into the better care for the children of the community. As Secretary General of Indian Academy of Pediatrics, I would like to congratulate the team behind this initiative of Journal Club, who's working day and night for coming up with this novel idea. And these kinds of initiatives will definitely encourage every IAP member. And we also request all of them to actively participate and make this Journal Club a dynamic space for learning and collaboration. And I wish this journal club great success. Thank you. Over to Nikhil.
Thank you very much, ma'am. So before we start, I would just like to mention Dr. Aradhana. She is the convener for this journal club, and she has been behind me for getting it as early as possible on the platform. So I would just like to mention that it is all her hard work that we are getting this first thing online. And another thing is to the team of Journal Club, Pinakin, Trupti Joshi, Pinakin Chakravarti, Trupti Joshi from my own city, Dr. Suman, Dr. Sharmila Joshi, the team which has been working to get this thing rolling on. And we would like that this thing continues, and we will be presenting it twice in a month. And we hope that you all would be able to benefit from this journal club. Now, to take the things further, I would like to hand over the further thing to Dr. Aradhana. And so she can just introduce the speakers and the moderators and how the flow would go. So over to Aradhana, ma'am.
Thank you, Dr. Nikhil. So without wasting time, I should go ahead. And yes, I need to mention some other team members are very crucial team members, Dr. Trupti, Dr. Priyanka, Dr. Nihal, Dr. San, and of course, Dr. Pinaki. So all of us are here. And I'll be inviting the expert for this discussion, our esteemed faculty, Dr. Venkatesh, who is consultant neurologist, head of the Department of Neurology, Manipal Hospital at Bangalore. And to facilitate the discussion, I invite Dr. Pinaki Chakravarti, who is SNCU in charge, Silchar Medical College, as. So over to you, sir.
Yeah, thank you. All the President, Secretary, and the team of IAP Research Journals. So with Venkatesh on board, I would have the talk on from the experts, because the topic once we were selecting was which journal or topic should come first. And we thought of getting the newborns first. And as we know, delayed cord clamping, the practice of waiting for 60 seconds or till the cord pulsations ceases. So this is still a debate, and we found the best study from SSKM Hospital under Professor Dr. Bijan Shah and Professor Dr. Shagata Chaudhary, who will be moderating the session. So I welcome Dr. Bijan sir and Dr. Swagata sir. And this will be also the co-authors in this are Dr. Ashadur, the DM, the resident there, and Dr. Rajiv, who was also an author. So having gone into the other topics of it, so let us start with Dr. Ashadur, who will be starting with the study how we have, and accordingly we'll be taking the opinion from the moderators, the expert, and we'll proceed further. So Dr. Ashadur, please start how we started with the study on.
Yes, good evening. Hello, am I audible?
Yeah, please go
I
ahead.
think Dr. Rajiv will start with introduction and hello, Dr. Rajiv.
Yes.
Yes,
Yeah,
start.
Dr. Rajiv, you are here.
Yes,
Please.
and so very good evening to everybody. Neelam ma'am, Singravallu sir, Rushika ma'am, Nikhil sir, Aradhana ma'am, and Venkatesh sir, and also our Bijan sir, and IAP especially for giving us this opportunity to present this paper. Being a part of this paper, I'll be presenting from the background, like why we wanted to do this study, up to the methodology part, and Dr. Asadur will be taking up from the results until the conclusion and the take-home points and all from this paper. So, with your permission, can I start? And am I audible?
Yeah, you are audible, Rajiv. Please go ahead.
Yes. So, like when we're planning for this study, the background, like so, this was published in European Journal of Pediatrics on February 6, 2026. It was registered under CTRI, as is mandatory for all, as you all know. So about the journal, it is published by Springer and it is ranked as Q1 in the Journal of Pediatrics, Perinatology and Health, and it is an indexed in most of the major bases. So in this journal club, we'll be discussing on specific headings. So first will be the introduction or the background. Then second will be like what are the gaps in knowledge that we wanted to fill through this study. Then the research question and hypothesis. Then a little bit about the review of literature that we did. Then the objectives, materials and methods. Then results, discussion, conclusion, and what could be the applicability of the findings that we found in our study in our own settings. So first, the background. Now, as you all know, DCC is now universally recommended in all vigorous neonates at birth, irrespective of gestational age. So, all the NRP guidelines, in all the major guidelines, we know that it is universally recommended, but the only point is that the baby should be vigorous at birth. ILCAR guidelines and NRP now recommend deferring the cord clamping from 30 to 60 seconds now to at least 60 seconds. So that is one of the changes that come up in the recent NRP 9th edition. Initially, it was mentioned for at least 30 to 60 seconds, but now it is mentioned that it should be at least for 67. So now 1 minute is mandatory according to NRP 9th edition. So according to previous studies, delayed cord clamping involves the transfer of placental blood, and it is seen that in some studies, it could be like approximately it reaches 80 ml by 60 seconds to 100 ml at 3 minutes. So there is a gap of around 20 ml that is transferred more to the baby if we defer the cord clamping to 3 minutes from 1 minute. There was a study that was published in 2022. So regarding the gaps in knowledge, it is universally recommended as a routine practice, but there are few potential risks that we fear about, like increased rates of polycythemia, neonatal hyperbilirubinemia, and the requirement of phototherapy. So these are certain doubts that we have in our mind when we keep on delaying the cord clamping for a certain period of time. But those studies that had mentioned about this risk did not have high certainty of evidence. In fact, they had all low certainty of evidence. So whether these potential risks are real or not, that is not sure till now. So there is no uniformity regarding its definition of what should be the ideal duration. It should last anywhere from 1 minute or more or until the umbilical cord pulsation ceases, like Minaki sir already told. So we still don't know till what period we should wait. Very few studies regarding the duration in the preterm population. And when we'll review the literature, then we'll find that most of the studies that was done on this duration was mainly done in term babies and one or very few studies in late preterm and term babies. But there are we did not find much studies that were done exclusively in the preterm population. So more evidence was needed to be generated in order to determine the correct duration. So given the lack of agreement on the base duration, this study was conducted to compare the effects of 1 minute versus 3 minute deferred cord clamping on hematological parameters and clinical outcomes in neonates of 30 to 37, that is 1 day, 30 to 36 weeks of gestation. So that was the rationale of this current trial. So what was our research question? That was framed on the PICO format. As you all know, P stands for population, I for intervention, C for control, and O for outcome. So in that research question, our population was preterm singleton of 30 to 36 weeks gestation. Whether in that gestation, DCC for 3 minutes, that was our intervention, versus DCC for 1 minute, that was our control, and our outcome was venous hematocrit at 48 hours of age. So whether in that population, DCC for 3 minutes can lead to higher hematocrit or not, that was our research question. So what was our hypothesis? We hypothesized that extending the duration of DCC from 1 minute to 3 minutes would enhance placental transfusion, resulting in higher venous hematocrit at 48 hours of age compared to DCC for 1 minute in the population that we already mentioned. So before going for the study, we did the review of literature. It was done in all the popular databases like PubMed, Cochrane Library, Google Scholar, and other net sources. And we found few studies like, but as I have already mentioned, most of the studies were done in term units. The first study was that is seen in the table. It was published in 2010. It was done in term neonates. The sample size was around 276. It was early cord clamping versus delayed cord clamping at 1 minute versus delayed cord clamping at 3 minutes. The results that was found was that serum ferritin levels were significantly higher in the infants of the 3 minutes group. So that was the finding in the study of 2010. 2018, again in term neonates, 720 was the sample size. There, immediate cord clamping was compared with DCC for 30 seconds, 1 minute, 1.5 minute, 2 minute, then 2.5 minute, and 3 minutes. On the last one was when the umbilical cord pulsation ceased, and it was found there that the mean hematocrit levels increased according to the duration of DCC. So the highest was seen if we waited till the umbilical cord pulsation ceased. Then this study by Katari et al. In 2021, again done in term infants. There also there were 3 intervention groups. One was DCC for 1 minute, one for 2 minutes, and the other for 3 minutes. Again, at 24 to 48 hours of age, it was seen that hemoglobin levels were higher when DCC was delayed up to 3 minutes. Then this study by Chaudhary et al. Published in 2023, the population was late preterm and term infants. Again, 3 intervention groups, 30 seconds, 60 seconds, 120 seconds. Again, DCC at 2 minutes was associated with a significant increase in the mean hematocrit by around 2%. So these were the few important studies that we found during our review of literature. And as can be seen, there are very few studies that has been done in the preterm population. And this was done in the late preterm and term infants. That's why we thought that we need to do a study exclusively in the preterm population to know whether those benefits extend to that population as well. So what are the primary objective? Our primary objective was to measure the venous hematocrit at 48 plus minus 4 hours of postnatal age. Our secondary objectives were to measure hematocrit at 12 hours, 48 hours, and 6 weeks, to measure serum ferritin at 6 weeks of postnatal age, to assess heart rate, mean BP in the first 48 hours, risk of jaundice necessitating phototherapy, polycythemia in the first 72 hours, incidence of hemodynamically significant PDA because we are dealing with a preterm population, retinopathy of prematurity stage 2 and above, NEC stage 2 and above, IVH on cranial ultrasound, bronchopulmonary dysplasia, total number of PRBC transfusions that were needed during the hospital stay, and date during hospital stay and length of hospital stay. So coming to the materials and methods, so this was a stratified, sorry. Is it my screen is being shared? No.
Yes, sure.
Huh?
Yes, it is shared.
But I'm not finding it. Okay. Just excuse me for just 1 minute, please. Is it being shared?
Yes,
Yeah,
yes.
Ajit,
Yes, yes,
it's
sure.
finished.
No, sorry.
Please go ahead.
Okay.
Yeah,
So
because,
now,
yeah, that-
now coming to the materials and methods. So first, what was our study design? This was a stratified randomized control trial. It was a parallel group study with a 1:1 allocation. Our study settings, study period was conducted between November 2024 to August 2025. Study population was preterm singleton of 30 to 36 and 6 by 7 days weeks of gestation. Place of study at a tertiary care center in India in the Department of Neonatology and Obstetrics and Gynecology. This study was approved from the institute, the number being given, and it was registered with CTRI. And written informed consent was obtained prior to study participation. What was the inclusion criteria? Inborn singletons of the specified gestation. Exclusion criteria, neonates born than less than 30 weeks or more than or equal to 37 weeks of gestation. So it was exclusively a preterm population. Non-vigorous neonates were excluded because that DCC is not still recommended in those neonates. Those born with major lethal congenital abnormalities or known suspected chromosomal anomalies were excluded. RS negative pregnancies were excluded because it is not still DCC is not there is still doubt whether it should be carried out in RS negative pregnancy or not. Those whose residence was beyond 20 kilometers radius was also excluded from this trial. What are the intervention that was carried out here? The intervention done was deferred clamping of the umbilical cord at 2 different timings, 1 minute or 3 minutes after delivery, and as allocated after randomization. So our intervention was 3 minutes DCC and the control was 1 minute DCC. So here is a video. I don't know whether it will be played or not, but I'll try it. This was a video that was taken during the study period from our own institute. You can see Sogata sir in this video who is doing the delayed cord clamping for there. So I think, and it was done in an LSCS baby. A baby was born through LSCS.
Sure.
ঠিক আছে হ্যাঁ 1 minute over.
Okay, so that video was shown because many people have doubt whether this DCC is really practical or feasible during the LSCS is or not. But we found that with a properly trained staff and all, delayed cord clamping is feasible and practical even in cases where babies are born through LSCS. So in this study, prior to cord clamping, neonates born by vaginal delivery were kept on the mother's abdomen, and those born by cesarean section, because the abdomen was needed for the obstetrician to carry out their surgery, they were placed on the chest of the mother, which helped also in skin to scare as part of our unit protocol. Both baby and mother were covered together with a pre-warm towel, and in accordance with the unit protocol and standard guidelines, all the hemodynamic variables such as BP, heart rate, and other hematological and clinical parameters required for primary and secondary outcome measures in this study were evaluated and documented. Next is our sample size calculation. How did we get our sample size? The sample size was calculated based on the findings that were found in a previous RCT comparing DCC for 1 minute versus 2 minutes. The sample size was calculated using OpenAPI version 3. There it was necessary to enroll 127 neonates in each arm of the study in order to achieve a 90% power and a two-sided alpha level of 0.05, which is usually the norm. But we also included 25 additional newborns in each group to account for a 20% loss to follow-up that could happen during the study period. Therefore, ultimately, we found out that we needed 152 newborns in each group for this study to be conducted according to the things that we needed. So the ultimate sample size was 304 neonates, which was equally divided between the two arms in 1:1 randomization. So DCC for 1 minute had 152 neonates and DCC for 3 minutes had 152 neonates. The total study sample was randomized into two groups in 1:1 ratio by stratified block randomization according to gestational age from 32 to less than 34 weeks and 34 to less than 37 weeks with variable block sizes with unique randomization code which was generated online. So those of us, most of us know that if we go to the sealedenvelope.com, that site, and if we put in our data, they help us by creating their own list of this randomization search. So we obtain this randomization search after we put in our information in that particular site, then we got the randomization site according to the and also the subcategories. So how did we go about the blinding? A nursing officer from the Ops and Gynae department opened a sealed envelope following the baby's birth. The nursing officer was blinded to the study. However, due to the nature of the intervention, this was not feasible for the neonatology resident attending the delivery because if we delay it for 3 minutes or 1 minute, definitely we will come to know about that the category. However, the outcome assessors who did the final analysis and the final data summarization, they were blinded to this study. Statistical analysis, the data was summarized by routine descriptive and inferential statistics using the Statistica version 8 and Metcalc version 23.2.1. This was done by our Hazra sir. Continuous variables were calculated through mean and median by mean by standard deviation and median by interquartile range for descriptive statistics. And when it for the same continuous variables for inferential statistics, student t-test and Mann-Whitney u-test was used. For categorical variables, for descriptive statistics, number or percentage was used, and for inferential statistics, chi-square and Fisher exact test was used. Statistical significance was set at p value of less than 0.05, which is usually the norm. Data analysis was done on an intention to treat basis. Subgroup analysis, this was done according to the gestational age of 30 to less than 34 weeks and 34 to less than 37 weeks, so that we could know if those subcategories, the results and all could vary or not. And it was done on an intention to treat basis, means whoever started on the study, ultimately analysis was done on them. So thank you from my side. Now Dr. Asadru will present you the results and the discussion and the conclusion.
Thank you, Dr. Rajiv. I will continue with the results. I will share my screen. Is it visible? Is it visible, Dr. Rajiv?
Visible, visible.
Yes, I will go. Good evening to all panelists and President, respected sirs, madams. I will continue with the results. First of all, consort flow diagram of this study. Enrollment was, we assessed for eligibility, total number 359, out of which 55 were excluded due to different exclusion criteria, and ultimately randomized to 304 infants. So allocated into two groups, DCC in 1 minute and allocated to DCC 3 minute, 152 in each group. Out of this, in the 1 minute group, subgroup strategized 30 to 33 plus 6 weeks, 76, and 34 to 36 weeks gestational 76 in both this 1 minute and 3 minute. Follow-up was done in the 1 minute group. Loss to follow-up was 2 and expired 6. And in 34 group, loss to follow-up was 5 and expired 1. So ultimately analyzed in 30 to 33 group, 68 babies, and in 34 to 36 weeks gestational is analyzed 70. In another DCC 3 minute group, we analyzed in 30 to 33 week 68 babies, and in 34 to 36 weeks analyzed 70 groups. Baseline characteristics in the form of maternal age, antenatal corticosteroids, gestational age, conception, birth weight, male sex, mode of delivery, maternal anemia, small for gestational age, iron supplement, SNAP-2 score, and Apgar score, all were comparable between the groups. Now, this primary outcome of this study, primary outcome was venous hematocrit at 48 hours, plus minus 4 hours. In the 1 minute group, it was 41.02, while in the 3 minute group 43.18, and p-value was significant. In secondary outcomes, we have hemoglobin and hematocrit at 12 hours, 48 hours, and hematocrit at 6 weeks, all were significant. However, ferritin at 6 weeks in this preterm study, ferritin at 6 weeks between 1 minute and 3 minutes were not significant. In previously, we have shown that in the term population, that study RCT showed ferritin was significant. And other secondary parameters like need for phototherapy, symptomatic polycythemia, shock, recurring inotrope in first 48 hours, sepsis, blood culture positive during hospital stay, babies requiring packed RBC transfusions during hospital stay, hemodynamic significant PDA, severe grade of IBS, grade 3 or 4, NAC stage 2 or more, ROP recurring treatment, bronchopulmonary dysplasia, death during hospital stay, and hospital stay in days were not significant between the groups. Line diagrams shows this hemoglobin, hematocrit. Now subgroup analysis between 30 to 33 weeks, we have 1 minute and 3 minute p-value or significant in 1 minute group, 40.76 hematocrit, while in DCC 3-minute 42.88, and p-value was significant. In the 34 to 36 weeks, it is also significant, 41.3 and 43.48. And other secondary parameters like heart rate at 1 hour, heart rate at 6 hours were not significant, also heart rate at 48 hours. However, mean arterial pressure at 6 hours and mean arterial pressure at 48 hours were significant in both the groups. In the here also in ferritin 6 weeks and was not significant between the groups. In subgroup strata 33 to 33 and 34 to 36 weeks, and hematocrit at 6 weeks, it was significant in both the subgroup strata. Now discussion. So these findings support the hypothesis that prolonged placental transfusion allows a more complete.
Dr. Ashadur.
Yes.
Dr. Ashadur. So may I request our expert Venkatesh sir, before we proceed for the discussion, sir, any comment or anything on the methodology and the results they have come?
Thank you, Dr. Pinaki. I think first of all, I thank IAP to involve me for this discussion as an expert one, and also I congratulate all the authors for coming out with a fantastic article, which is essential for the day, especially in developing countries like us. I think wonderful, and I think I'm very happy that there are strengths and weaknesses in this. One important strength they have done for 1 and 3 minutes, and they have taken actually preterm babies, where most of the studies have been done on term babies. That's very important.
Term babies.
The other important thing here, though it is an open label, we know that it is not blinded, but one important they have done is the stratification. So that actually compensates. For one important issue here is why they have done open label, because most of it is impractical to do what is called as blinded in this, because somebody has to observe the baby condition or distress. Coming back to the introduction part, I'm okay with that. Only thing I'm a little bit worried about what exactly the knowledge about the vaginal delivery versus C-section. I think that must have been incorporated in the introduction also. But because naturally what happens when the baby gets blood from the mother, uterine contraction is very, very important, which is very active in normal vaginal delivery. And I think that one information that would have come in the introduction part. The second thing I was thinking that they have commented only on the polycythemia and hyperbulimia, not commented, though it was now if I see the analysis stage, they have looked at necrotizing enterocolitis, IVH, and some of these things are not incorporated in the introduction part. I think that is one. The second thing, if you take materials and methods, it is actually 1:1, but the thing is inclusion criteria should be clear. Inclusion criteria, they should say vigorous babies. That is one. There is no need to write non-vigorous babies in the exclusion criteria. The inclusion criteria should be specific that all vigorous babies. The second thing I was thinking that this is for the audience, and I know that a lot of students also here. And once it is written, actually in the inclusion criteria, 30 to 36 weeks of gestation, there's no need to write again the exclusion criteria that 30 and 36 weeks are excluded. I think these two things I was a little bit thinking about to inform you. And other important thing here is, I know that it is done intentional analysis and the statistical analysis also. If you look at the data, what they mentioned here, for example, the primary and secondary outcome measures. And all these things, what they have done is, if you take HSPDA requiring medical treatment and severe IVH, the sample is very, very less there. It's only 3. It is underpowered. And because it is underpowered, it's very difficult to prove which side it is beneficial. That's very, very important. Because the number is too less and it is underpowered and difficult to prove. And apart from these things, I think I'm okay. I think it's fantastic.
Thank you, sir.
Thank you, Venkatesh sir. So,
yeah,
any comment from our moderators, Bijan sir and Dr. Saugata, that specifically inclusion criteria having mentioned, we should not have highlighted much on the exclusion criteria. And anything else you want to have?
Thank you very much
for giving us the opportunity to present our article in this forum. Some of the things what have been highlighted by our expert. Let me start with introduction. I think most of the participants who are watching this program will be postgraduate students. When you write an introduction, your introduction should include some of the important points. First is background, gaps in the knowledge, and what you want to do. And most of the time, introduction usually highlights the primary outcome, because the sample size is calculated based on the primary outcome, not on secondary outcome. Definitely, what the expert has highlighted is okay. Necrotizing antilocal is another thing is there. But think that when you are writing an introduction for any article, you should first think of what are the central points in your article. In this particular study, the central point is that if you actually make 3 minutes, what will happen to the hematocrit and ferritin? They are the primary outcome. Because in introduction, you cannot stress upon everything. But in the previous study, if you look at the previous study, there was some concern on polycythemia or necrotizing antilocal, whatever. But our main aim of the study was to see the hematocrit level, hemodynamics, as well as ferritin level. Because if you defer the clot, that will lead to another 20 to 30 ml per kg of body weight blood from the placental side to the baby. Second important thing is that whenever you are highlighting or writing an introduction, at the end of the introduction, you have to actually mention what is your objective. And that objective usually focus on the primary outcome. Second important thing, you can take 1 or 2, 3 primary outcome, but most of the clinical study, biomedical research, you take 1 outcome. You can take 1 or 2, 3 primary outcome. Then when you are calculating sample size, you can calculate the sample size for all those 3 outcomes. And based on the outcome where the sample size was maximum, that we have to take. Second important thing, what Dr. Venkatesh has highlighted, that I agree. Actually, when you write 32, 36, it is already implied you should not write 37 weeks. I think that is the one he has rightly pointed out. Third important thing that is that about the statistical analysis. See, in the statistical analysis, whenever before you actually do any study, you have to think of what you are going to do. Here, the statistical analysis is mainly focuses on the primary outcome. And if you get some important significant finding in the secondary outcome, that is already always be underpowered, because sample size was calculated based on the primary outcome, not on the second. Suppose your ferritin level is suppose there is mean arterial blood pressure was significantly higher in the 3 minutes group, or hemodynamics stability was more significantly increased in the 3 minute group. Even there was some significant finding, you cannot talk with a lot of confidence that because this was not powered and sample size was not calculated with this. What he has highlighted, that is good. Sometimes you get some finding in the secondary outcome. Next time when you're planning for another RCT, then you take as a primary outcome and you calculate your sample size based on the sample size based on those outcomes. His points are well taken. And second important thing is one important point what he has highlighted. Yes, sir.
So sorry to interrupt. So at least this should have been written in the discussion, no? It is underpowered.
Yes.
That was not there as a thing. Yeah. Thank you. Go ahead, please.
Thank you, sir. I will continue with the discussion part.
So I think should I carry out or Dr. Sadhu should continue?
Please go ahead, Dr. Vian. That I thought actually because this is underpowered statistical, I understood, but it was not highlighted in the text. That was the thing.
Yes. And another important, as he has rightly said, and some of the points is well taken. And third important thing is the intention. I think I'll ask our presenter what is intention at the end of the discussion. Because intention once it is randomized, it is always analyzed. That means even there is some loss to follow up, then you will analyze. So one important point of the sample size calculation is that you took 90% power. And that inflated the sample size. So, but in our biomedical research, you can take 80% powers for any research. But if you take 90% power, the definitely sample size will increase. And just going back to introduction, because so many postgraduate students are there. Whenever we see any thesis, any paper, especially dissertation, we had a notion that somebody has done some work. I have also done, and my finding is similar. That is study. That is not study. Whenever you are planning to do something, it should come to your mind what is you are going to do. Suppose some ideas come to your mind, then you have to check and go for the review of literature. You see, if somebody has already done this work, then there is no point of doing this and wasting time. So that you should keep in mind. So whenever you plan a study, it may be observational, it may be experimental, there should be some new angle. There should be some gaps in knowledge. Otherwise, this study will not carry any meaning. So just somebody has done this work, I have also done the same work, and my finding is same. So he has found this thing, there's not. I think with this, we can move ahead with discussion. At the end of discussion, we can again carry forward our discussion again. Thank you.
Yes, sir.
Thank you, sir.
Yes,
We
Arshad,
will continue
thank you,
with
sir.
the discussion.
Arshad, go ahead. Yeah.
Yes.
So our study findings support the hypothesis that prolonged placental transfusion allows a more complete transfer of blood volume from the placenta. Previously told 1 minute 60 ml and 3 minute 100 ml, leading to improved hematological parameters, better circulatory stability, hemodynamic stability in preterm infants. So pregnant women are frequently diagnosed with iron deficiency anemia, especially in developing countries like us in India, as is also evident from our study. And infants' neurodevelopment is negatively impacted by the perinatal iron deficiency. So better iron stores during the first year of life provides protection against infection in infancy and is highly relevant to low and middle income country settings like India. Extended deferred cord clamping in preterm neonates may help decrease the incidence of anemia in infancy and thus improve long-term neurodevelopmental outcome. Anderson et al. Demonstrated improved 4-year outcomes in term infants receiving 3 minutes of deferred cord clamping compared to early cord clamping. It is possible that preterm infants may have ever greater benefits given their high risk of neurodevelopmental impairment. So the physiologic rationale behind prolonging cord clamping lies in optimizing placental transfusion during the critical transition from intrauterine to extrauterine life in preterm neonates who are often compromised by immature hematopoietic and cardiovascular systems. Adequate placental transfusion can support better blood pressure stability and improve tissue perfusion, which are important for transitional circulation. Our findings reinforce this mechanism as infants in the 3-minute group had statistically significant higher mean blood pressure in early neonatal period. So there are some limitations in our study. So one of the told that not adequately powered for secondary outcomes. These was limitations, and long-term neurodevelopmental outcomes were not evaluated. This study would become more robust if we followed these neurodevelopmental outcomes, but we are planning another studies for long-term neurodevelopmental outcome follow-up. Conclusion: extending deferred cord clamping to 3 minutes provides hematological benefits without increasing the risk of adverse neonatal outcomes, and it is simple, low cost and effective strategy in delivery rooms, particularly in developing countries where baseline prevalence of anemia is high and it does not need any hi-fi device or gadgets in the delivery rooms. So what is already known? Deferred cord clamping is universally recommended for vigorous neonates at birth, but no consensus exists for its duration. Studies on the effective duration of deferred cord clamping are scarce in the preterm population. So what this study at deferred cord clamping 3 minutes is an effective placental transfusion strategy in preterm neonates of 30 to 36 completed weeks of gestation. Deferred cord clamping for 3 minutes can be an important strategy, especially in developing countries where the baseline prevalence of anemia is high. So applicability in our setting, the practice could be integrated into neonatal resuscitation protocols provided that the infant is hemodynamically stable and obstetric conditions permit. There is also IFE, NNF, NRP protocol. So we can consider this in our settings. So critical appraisal skill checklist program. Did the study address a clearly focused research question? Yes. It was designed to address the outcome of an intervention, and research was focused in terms of intervention, population PICO, comparator, and outcome. Was the assignment of participants to intervention randomized? Yes. Were all participants who entered the study accounted for its conclusion? Yes. Where the participant blind intervention were given, it was not possible. Only outcome assessor were blinded due to nature of the study. Where the study group similar to the study of randomized control trial, yes, baseline characteristics were similar. Apart from the experimental intervention, did each study group receive the same level of care? That is, were treated equally? Yes, absolutely, yes. Were the effects of intervention reported comprehensively? Yes, power calculation undertaken, outcome were measured and were clearly specified. Was the precision of the estimate of the intervention treatment effect reported, confidence intervals given? Do the benefits of experimental intervention outweigh the harms and costs? Yes, we can tell now at this stage. Can the results be applied our local population? Yes. Would the experimental intervention provide greater value to the people in your care than any other existing interventions? Yes. So thank you. And any questions from the?
Thank you, Dr. Ashadur and Dr. Rajiv, who first started the introduction until the methodology part. I think it is really a very nice study done from SSKM under Bijan sir and the team. And delayed cord clamping, as we all know, is more of we are discussing, but how much delay and whether we can take the obstetricians into loop. That is a big challenge as we are facing. Otherwise, implementation up to 3 minutes is a real challenge. And I again thank the SSKM team led by Bijan sir to get it done for the preterm population for the 3 minutes. Now, from the moderators and Venkatesh sir, the topic is open for discussion, and any of our IAPNs who have joined here or the PGs, they can put forward the question in the chat box. And I request Venkatesh sir to put a final comment, and Bijan sir and Dr. Shalvata to please go ahead.
So thank you, Dr. Pinaki. So only thing I just wanted to tell, because statistical, just I'll give 5 minutes talk on what statistical, because the students are also sitting in this forum. So very important here is there got numerical data and categorical data. That's very, very important. We need to divide the data. And the numerical data, if we take into consideration, if we take for the numerical data, the mean and standard deviation they have used, and also non-parametric Mann-Whitney U-test is used. So this is very, very important. Whenever there is a data, you need to divide numerical data and the categorical or qualitative data. Here, the categorical data they have used two important tests. One is fissure exact test and the chi-square test, because they should know that which data. If we take the tables here, for example, baseline characteristics of mother and neonates, if we take the table 1, there actually they have taken on the mean and standard deviation because the sample size is large. Because the sample size is large, the Gaussian curve is normal here. I think mean is taken into consideration for them. There are, if you take into consideration that A and B, they are written actually marked, the variables. The A is mean and standard deviation. That is actually for what is called numerical data. And number is given, the percentage here. The B, that is all categorical data, where the chi-square test and the fissure exact test is used. The only difference to take into consideration, if we take categorical data, fissure exact test is used for small sample size and the value is always exact. That's very, very important. Whereas chi-square test is easy to do, but the exact test requires, it is very cumbersome and it requires the computer program to have that. That's another very important thing. I was also looking at all these variables. If we take table 2, there are certain variables that they have measured in different timings. And here, if we take these hemoglobin at 48 hours, hematocrit, MAP, and everything, that is statistically significant, less than 0.001. That's very important. Why I'm coming with this point? Because if it is not significant, it was like 0.05. Whenever we multiple times when you do the same variable, we should use what is called correction value, called Bonferroni correction. That's very important for this. But here, Bonferroni correction is not required because the p-value is very, very low. If you are in doubtful p-value is significant or not, Bonferroni correction should be used. Bonferroni correction again for the candidates, if it is like 0.05, you take that value, divide with the number of items. For example, hemoglobin is done 3 times. You multiply by 2. 0.05 divided by 6 will give you what is called as the statistically significant or not, depending upon the alpha value. Other important thing I was talking about, what is called as the line graph. I think, can somebody show line graph there? Because whether the candidates here sitting as postgraduates, whether they understood or not, I just wanted to comment on this line graph. Yeah. So if we take the line graph here, mean hemoglobin, mean MAP, mean hematocrit, and mean heart rate, there are 2 important things are there. One is called measured variable on y-axis and the timing on x-axis. This is very important. There are 2 trends you can see. There are 2 important points. What we see, the round balls, they are the mean point. And what we see, that extension, it is not standard deviation, it is standard error of mean, which shows precision. Smaller this, if you take, for example, mean hemoglobin compared to the first one, and the second one is a bit smaller than the first one, that will indicate smaller the standard error measure. For example, the vertical bars, what we see is a standard error of mean. If the standard error of mean is small, precision is more. And these are very, most of the times actually students get confused. That is a standard deviation. Standard deviation is different from standard error of mean. Standard deviation, what does it indicate? It shows data spread within your sample. That's all. Whereas precision is different. Standard deviation, you have to divide by the square root of the sample, whatever you get. That will give you the precision. And that's how you have to read this. So if you take into consideration, you can see all the things. If you take, for example, mean MAP at 48 hours, there is the huge standard error of mean. That means precision is very less here compared to the 6 hours and also the first hour. So that's how the graph has to be dealt with whenever there is a statistical analysis done in the line graph. So anyway, thank you so much. And it was wonderful discussion. And of course, I think as rightly said, only thing I was thinking that why there was no normal vaginal delivery. It's all C-sections. I didn't see any. If you take, for example, if you take this table also, they have mentioned it's only C-section.
No.
Mode of delivery. Interesting.
I think it is not correct. I think that is a mistake. There was normal delivery action with more maximum number of normal delivery.
Sir, can I just say, sir?
Please, yeah.
Sir, actually, what we wanted to mean through the table is that, like 50% were C-section in the DCC and 46 in the DCC 3 minutes, sir. So rest 12 are normal delivery, sir.
Normal delivery.
Rest are normal delivery, sir.
Sir,
the reason why, because if we don't mention that one, we don't know at 1 minute what and at 3 minutes what.
So, sir, we thought that, sir, we'll mention the C-section that percentage so that the rest will be normal delivery.
Thank you.
Rest are normal delivery.
Thank you so much.
Thank you, Dr. Venkatesh, for the excellent discussion on the statistics part of the there were some questions from the audience. One question was there, please explain the data imputation done for intention to take analysis or loss to follow-up cases. So, madam, let me tell you, if there is a missing data, then we can go for intention to treat analysis. But in this particular study, there was not such issue. But definitely, if there is some missing data, then one can go for the imputation. Imputation can be done. One is a simple way is that you can take the mean of the value out, what is there, and you can take the mean value. or you can carry forward the last value what it is there. That is one way of imputation. That's the easiest way. But in this particular study, there was no such case, so imputation was not required. And second question was there, Dr. Sanjeev has, unfortunately in India, the percentage of disease is still around 17% as per the year data. I think fully agree with you, sir. Actually, before this study, we conducted 2 other studies, the same team. One study of cut umbilical cord milking versus immediate cord clamping for babies who are born non-vigorous and requiring resuscitation. As you are rightly said that BCC is the standard of care, even in the United States and other developed country, the uniformity is not there. In India, as you are rightly said, it may be 17%. That's why we thought that if we can do something, that is for the babies who are, because for vigorous baby, already the recommendation is there, but non-vigorous baby, it is not there. So we did a study, cut umbilical cord milking versus immediate cord clamping in babies who require resuscitation. It was shown in that particular study there is significant increase in the hemoglobin and hematocrit level in babies who are born with non-vigorous, and their cut umbilical cord milking was done. Second important study, it was again with the same team conducted. This is for the twin infants, the multiple gestation. There is no study on multiple gestation. You are right. Although DCC or deferred cord clamping is the standard of care, that's why there is still need actually we should now implement what is there. And second, another question, how many studies have been carried out in India so far? As they have rightly pointed out the table, there another study was done, that was done is 32nd, 62nd, and 182nd, but that was in term infants and late preterm and term infants. So in India, there is not much studies. I think, madam, you have previously talked about a physiological based study done by Dr. But that is little bit different actually. Physiological based cord clamping means there is no need of time clock. As soon as the baby is bring, then you can keep the cord like that. But that may be counterproductive, because if you keep the cord intact and still the placenta is separated, that may cause more harm to the baby rather than doing good. Maybe that after that study, I have not found anything or any work on that. And one important part, even you wait for 5 minutes or 50 minutes, it cannot go more than 20 to 30 ml per kg body weight blood. So, but during this time, baby might deteriorate. So that is there. And the USA had recruited many centers from India for DCC short-term and long-term effects. Yes, one of the most important fallacy or drawback or what they have highlighted of the weakness of our study is that we have not actually done the long-term neurodevelopmental outcome. Because if there is improvement in the hemoglobin and hematocrit, and definitely they might have some effect on neurodevelopmental outcome. This is one of the major limitations of the study. About the discussion part, actually many postgraduate students are there that I want to say a few words. Discussion will be based on your finding or results. Whatever results you have got, you have to discuss those points only, not more than that. Like this, in this particular study, we got increase in hematocrit and ferritin level. One important point that we did not find in this one is ferritin level. So can I ask Dr. Ashadur, how do you explain this? Because there is no increase in the ferritin level at 6 weeks. Rajiv?
Rajiv and Ashadur, unmute. Yeah.
Yes, sir. We anticipated that the ferritin will be more at 6 weeks, but
we did not find anything.
Probably, sir. Actually, our study was not designed ferritin was not our primary outcome, sir. So if we had taken ferritin as the primary outcome, probably our sample size we needed more sample size for that. So probably that could be one of the reasons, sir. If we had more sample size, then probably we would have got. And another one thing is that, sir, ferritin is an acute phase reactant, sir. So ferritin is modified by many factors. So the baby's physiology and all those things could affect the ferritin level. So these two could be the reason.
Exactly. That could be the reason, because ferritin is the acute reason. Even it is increased, you cannot say with a lot of confidence that is because of this effect on the delayed cord clamping. We have to need to see some other markers which is more significant than this.
Yes.
Any other question from the audience? So you can unmute and ask directly.
And in some previous studies, they have ferritin done in a term population, and none other studies on ferritin in preterm population. And in preterm population, how ferritin metabolize or also acute phase reactant, how it behaves in preterm population. We don't know.
If we summarize, whenever you are writing a paper or do some dissertation work, first of all, you should have research question. And that research question comes to your mind based on your clinical work by doing a brainstorming or attending some seminar or presentation like this, or reviewing the literature. And once it comes to your mind, then you go for searching literature, you see what is the gaps in knowledge. And based on the gaps in knowledge, you have to come to for a primary outcome. And your sample size should be calculated based on the primary outcome. And secondary outcome may be many, but primary outcome usually 1 or 2. In the materials and methods, this is one of the most important part any research work, because if the methodology is weak, then most of the journal will reject your work, even it is a good work. And in the methodology, some of the important thing is as they have highlighted the inclusion and exclusion criteria. Second, there's a little bit of study center area, because if your number of delivery is less, you cannot include this much of it. So that's why always you have to see some little bit of your description of your study area, how many babies are born, how many pretermers are born, whether this is a feasibility for the study. Third important thing is the statistical analysis, because if it is a RCT, then it is become very easy because it is clear cut. You have to do a good randomization, allocation of the concealment, and blinding. And many people confuse allocation concealment with the blinding. You should not confuse. Here they have said allocation concealment 1:1. That means in the both the group, the sample size will be same. Third important thing, whenever you write the statistical analysis, you first write the descriptive statistics. Descriptive statistics means what you have to describe what you have got. But inferential statistics, that what is the means what is the inference you have drawn from your data. That's why in any RCT or any study part, there is a baseline characteristics. That means the baseline character. That means what is the description of your variables. Second important thing, how do you know that your randomization is excellent? Ashadur, based on descriptive statistics, you can say the randomization was optimum. If there is no statistically significant difference between the groups, that means randomization was
baseline
okay.
Baseline characteristics will be comparable in between the groups.
Comparable. And in the result, when you write a result section, you write the result and some salient findings, not the details or description. Many of us who do the mistake writing description or start discussing in the results section. There's only the results, and there will be 2, 3, 4 table. Finally, discussion. Discussion means whatever results you have got, you have to discuss those findings only, and you have to compare with the other studies for their external validity. Ashadur, what is internal validity?
Internal validities and external validity. Internal validities are how the results are applicable or valid in this population, and external validity and outside our study population, it is valid or not. Outside
See, internal validity is actually what we wanted to measure. Suppose I wanted to measure hemoglobin, and if my machine is not good, that means the validity is lost. Suppose I wanted to see the gestation is up to 32, 36 weeks. Our intention was to do the 36. If the 36 weeks is misly calculated as 37 weeks, that means validity is lost. That means what you wanted, whether you could do it or not. And second is external validity is generalization. Well, thank you. And you have to show the strength and weakness. Second important thing, suppose you have not got any significant finding, you should discuss that things also. And negative results are also published. It is not necessary that positive results should be published everywhere, and most of the journals are interested for vegetables. So even in the negative finding, you have to discuss the negative finding also. And lastly, the strength and weakness of your study. And these are the few ways we can conduct a randomized control trial. We have a little bit of experience of RCT doing in the delivery room. These are third RCT, who is what we could publish from our side. So thank you once again, and again thank you to all the organizers for giving us the opportunity to present our case in this particular platform. And special thanks to our Pinaki, because he told me some time back, sir, I have given your study and that has been accepted for presentation. So people are excited. Thank you very much. Thank you, Dr. Nikhil. Thank you, Dr. Aradhana. Thank you, Madam, and for giving the opportunity to hope to see you in future. And we will be interested to share with our some other randomized control experimental study in future uh, program. Thank you very much.
Thank you.
Over to Dr. Nikhil.
Thank you.
So,
Venkatesh sir, anything, any one-line comment?
yeah, so
Venkatesh,
always benchmark study to bedside, we don't take because we don't understand the article. So take home message is kindly read journals at least once or twice a month. Journal club should be a must for postgraduates. Thank you, Dr.
So,
Vinod.
Thank you.
thank you, everyone.
yeah.
So,
Yes, Nikhil, and one message just I wanted to highlight that what Bijan sir told, that the research should be specifically that where we don't have the studies done. Otherwise, most of the dissertation and then already studies done, they are being repeated and some way alteration, and this comes up. So this is really hard work of the whole team of SSKM that we could highlight, and ultimately we could measure because Nikhil was monitoring and getting the slot in the BGIAP where Nilam ma'am has put continuously one after another, and the whole people are in vibrant mode, and we whole team in the research group were working how to get the slot and the best so that we can give maximum input.
thank
So
you.
Nikhil, please go ahead.
Thank you very much. So it was a very wonderful discussion. Some things were eye-opening. Thank you, Bijan sir, Dr. Venkatesh. It was a very, very good discussion where we come to know that it's just not presenting the study, how to analyze it, how to look at the sample size, and how to interpret the results. So it was an eye opener, and it was a very well conducted session. Thank you, Pinakin, for moderating it. Dr. Aradhana, ma'am, again, thank you for taking the lead and getting this work done. Finally, a long list of thank yous. First, for IIP, Central IIP, our President, Dr. Neelam Mohan, ma'am, Dr. President-elect, Dr. Singhavelu, sir, our Secretary, Dr. Ruchira Gupta, all the zonal presidents, vice presidents, thank you very much for attending the thing. I would also like to just thank the core team of DGIIP, Dr. Ganesh Kulkarni, Dr. Nehal Patel, Dr. Vishnu Mohan, Dr. Swati Rao, and uh, uh, Dr. Swati Rao for their efforts. And finally, a big thank to the Journal Club team. So thank you, Aradhana ma'am. Thank you, Trupti, Sharmila Joshi, ma'am, for getting into this program and conducting it. We will again meet after 2 weeks on the fourth Friday for the next Journal Club, and hope we can reach higher heights than this time. Thank you very much. Thank you very much.
Thank you.
Good night. Thank you, everybody.
Thank you. Good night.
Thank you. Thank you. Good night.
Thank you. Good night. Bye.